Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi there, my name's Mike Sullivan, and I'm one of the instructors at Valor Medical Services. In this presentation, we'll be discussing Ventricular Assist Devices, also known as VADs, or VAD devices. Now, the National Registry outlined only one core objective for this, and it was they want providers to understand the functions of ventricular assist devices, basically how they work, kind of what the parts are, the common parts. Before we get into that, let's talk about what actually is a ventricular assist device, or what's a VAD. Well, it is a mechanical device typically placed inside the patient's chest where it will help the heart pump oxygenated blood throughout the body. Typically, it's installed from the base of the left ventricle, and it outputs into the proximal aorta. Now, this can replace or augment the function of the left ventricles in circulating blood. Sometimes it'll be implanted as a temporary treatment if a patient is just trying to get stronger, or pending heart transplant if there's not one available. Sometimes used as a permanent solution based on poor cardiac or low output. In some cases, if a patient's not a good candidate for a heart transplant or heart surgery based on their age or other medical factors, this can be used again as a temporizing measure. Now, there's different units on the market, and they're all going to be very, very similar in how they function. However, the controls and locations of different things may be somewhat different from unit to unit, from brand to brand. Now, as we look at the typical parts of a ventricular assist device, typically there's going to be some type of battery pack, more than likely more than one of them, and there'll possibly be either a charger or a power supply. Now, this charger or power supply a lot of times will be plugged into the wall to a standard AC outlet. It may have a charger where you can charge 2 or 3, 4 batteries in the unit itself, and it may have a power lead coming from that going directly into the controller. At the end of the day, whether the controller is run by 2 battery packs, or whether it's run by a power lead plug-in, or however it's run, there's typically going to be a motor inside that control unit. And in that control unit, it's going to take the electrical energy coming in, either from the batteries or from the AC outlet, and it's going to change that electrical energy into mechanical energy or kinetic energy. And that's where, again, it's going to start something moving. And when it starts moving is that percutaneous lead that works as a transmission between the control motor itself and the actual LVAD pump. Now, the best way to look at this is the engine of our ambulances doesn't actually run the wheels directly. There's actually a transmission between where the engine is and where the actual wheels meet the road. Well, in this case, the engine would be the control unit. The transmission that's carrying that energy that the engine is making out to the wheels, which is actually the LVAD pump, where that's what pumps the blood. Now, as we look at the LVAD pump, that's typically not something we'll see. It's not normally outside the patient's chest. It's normally implanted into the chest cavity, where one end is hooked into the base of the ventricle, and the other one is hooked into the proximal aorta. Now, in some patients, the ventricle may still be functioning partially. In other patients, it may not be functioning at all. These may be patients with heart failure who may have a very poor ejection fraction due to previous heart damage or previous injury, and as a result of that, they're going to have an LVAD implanted. Now, when we start assessing these patients, there's a few things we need to change. Our initial assessment as far as the airway and breathing will be the same. Level of consciousness will typically be the same as it would on anyone else. The big change comes in when we get into evaluating circulation. The vast majority of LVAD patients may not have a palpable pulse. Because of the fact that this pump is a centrifugal pump, it works on a continuous flow as opposed to our normal heart that pumps. This pumps continuously. So to determine if it's working or not, the best way to do that is to auscultate over the left chest and listen for some type of whirring or humming sound. That would indicate that the device is still moving within the patient's chest and pumping blood. Also, we can use mental status and skin findings to help evaluate the perfusion. Where we may not be able to check a radial or a carotid pulse, or we may not know if they normally have one or don't, this lack of a pulse, but the patient's talking to us, their mental status is normal, their skin status is normal, they've got good peripheral circulation, we would assume at that point that their circulation is fine regardless of the absent pulses. Another piece of our equipment that can get thrown off is our pulse oximeter. When we're trying to get an O2 saturation, we may not be able to get an accurate reading because of a weak or absent pulse. As you know, our pulse ox is used to reading based on a pulsatile cycle, so that may or may not work adequately with these patients. Now, as we look at their chief complaint, typically we want to determine if it is VAD related or not. And what I mean is the reason they called an ambulance today something to do with the VAD or a problem with the VAD, or is it something totally unrelated? Let's take, for example, we get called out because a patient was out shopping at the local grocery store and they've slipped and fallen and broken their arm. At that point, yes, they have a ventricular assist device in place and we need to know some of the basics of it. However, their chief complaint is a broken arm, not anything to do with the ventricular assist device. By the other token, if they're out at the grocery store and they suddenly lose consciousness and collapse and break their arm, then we'd have to think, well, is it circulation related? Could it be related to a VAD malfunction or a circulation problem? When in doubt, we'd always want to make sure that it's not VAD related. If it is VAD related, then we have some other issues to deal with. But if the VAD is functioning properly, the patient may well be perfectly stable regardless of what we see on the monitor or the lack of radial pulse, and it may be just something that can be treated at any facility, any hospital. If, on the other hand, the problem is a VAD malfunction, or it's not functioning, or the patient is extremely hypotensive, or they're unconscious, they're not perfusing their mental status adequately, those would all be likely VAD-related incidents. Now, when we try to deal with all these different VADs, like I said, there's a lot of different brands and manufacturers out there. Typically, the patient and their family will be more familiar with the VAD that they have and how it operates and where its connections are than any of our responders will be. In light of this, they should be our first source of information regarding the VAD and how it works. In addition to using them as information, they should have some type of laminated card with a phone number on it. Now, these phone lines are connected to the actual center that put the ventricular device in the patient's chest. The people staffing this are there 24/7 and can typically assist you with any VAD-related issues. These VAD help desks may be able to not only give you information about the device itself, but also help guide you with care and give you much more information about what the device is and how it works. So as we start to look at it, how does this change our management? Well, there's a few things. One big part is we always allowed the caregiver to ride with the patient, and always make sure to keep the batteries control unit with the patient. Many of the patients will have a tote bag or a rescue bag that they keep with them that not only has spare batteries in it, in many cases it may have a spare control unit in it. This is designed in case something happens, and let's say the patient, when they fell, landed on the control unit and somehow damaged the housing or the casing of it. The family members and the patient are trained on how to swap out one control unit for the backup. They're also, if they're dealing with an evacuation situation, they'll have spare batteries as well as potentially a deep cycle battery that will work for several hours. However, this should always be with the patient. We can't risk on it getting lost. We should always use extreme caution in removing clothing or placing any type of seatbelt. As I mentioned earlier, the line that actually goes from the control unit going in through to where the patient has the VAD itself, goes through the skin, that is going to be a line that has to continuously spin. So when we're putting seatbelts on the patient, if we crimp that line or squeeze that line, put undue pressure on it, it can actually prevent it from rotating adequately, the same way someone could squeeze the drive shaft of your vehicle, and that would cause problems. We can use IV fluid boluses just as we would with any other patient. We need to monitor breath sounds closely and be aware of the potential for breath sounds or potential for pulmonary edema. However, if we have a VAD patient who's having issues with perfusion, many times this can actually help a great deal. If we need to administer vasopressors, such as dopamine, these would be administered as usual with no significant change. If we need to administer electrical therapy, whether it be cardioversion or defibrillation, we can do this. We need to be sure to avoid placing the pads directly over the device. Now remember, we're going to administer electrical therapy in some settings to try to fix an underlying arrhythmia. However, that arrhythmia may still have the patient may still present as conscious regardless of the arrhythmia, just because of the fact the VAD is maintaining circulation. When we come to CPR, there's a few concerns we have. First off, we need to use extreme caution to make sure that we have the correct hand position. Not only that, but we need to watch our depth and avoid any excessive depth. If we end up damaging or dislodging the device from either end of its connection to the patient's circulation, the patient will likely suffer and die. As a result of this, yes, we can still do CPR, however, we need to be very cautious about it. Now, when we get into specific device guidelines, number one, consult with the family. They deal with this machine, they've lived with it since it's been put in for 24 hours a day. Look over the VAD ID card and don't be afraid to consult with the VAD device coordinator. If we're dealing with a patient that has a VAD malfunction, the VAD device coordinator may end up actually requesting an alternate destination or an alternate transport site. Given the fact that there are certain facilities that can handle these, that can troubleshoot these, and if necessary, get in and fix these, ideally the patient, if it's a VAD-related problem, should go to actually where the VAD was put in. As a result of that, we talk to the VAD device coordinator. We may actually end up transporting the patient or calling for an air unit to transport to an alternate destination that is not in our normal transport plan. This is done again to make sure the patient goes somewhere that can actually manage a VAD patient, as opposed to our normal local community hospital or even our local heart center, because in these cases, they're not going to be able to manage that VAD. If there's a problem, they need to go back to the dealership, so to speak. In closing, we're now starting to see more and more patients coming out with VAD units. As more and more of the patients enter the communities and are at home, there's a greater device that will come over across one of them. As emergency responders, we need to have at least some idea of the familiarity with the different devices and at least know that, okay, this is going to be a significant game changer for us, not only for our assessment, change slightly our management, and may definitely change our transport destination. Lastly, given the variety and diversity of these devices, in many cases the patient and their family will be our best source of information on this. We could go over right now in 20 different devices, and there's no guarantee those will be the ones that are in use next month, next week, or next year. So please use the resources you have. If you have any questions on this, please feel free to drop me an email. My address is on the screen. It's mike@valormed.net. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.